Thank you very much indeed, Alan. It's a great pleasure to be here at this wonderful meeting and seeing so many delegates coming out onto a slightly snowy London. I was surprised to see snow in London. I'm used to coming from snowy north and finding it sort of balmy in the south. So the guidelines, the perinatal guidelines, deal with a whole raft of psychotropic medications. We try to be as comprehensive as we possibly could be with regard to psychotropic medication. So it is rather important to emphasize that I have engaged with the pharmaceutical industry, and therefore you might think that I have a conflict of interest. I'm not sure that we were necessarily particularly recommending the recommendation of many drugs, as you are going to actually see in due course. So I don't think it is so much of a conflict as a declaration of interest. So Alan mentioned the British Association for Psychopharmacology. It's still probably, it depends how old you are as to whether you think this is a young organisation or an old organisation, founded in 1974 to advance education and research into the science of psychopharmacology. And the consensus guidelines are an important element of the educational aim of the BAP. And as Alan's already mentioned, the BAP has a large stable of guidelines, depression, bipolar disorder, schizophrenia, ranging through all of the sort of major conditions that we deal with in mental health. The perinatal psychiatry guidelines are one of the newest additions to the stable. I mean, we're on the third edition, for example, of the depression guidelines, and yet we've only just produced a guideline with regard to perinatal psychiatry. And one could argue why, or discuss why it's taken us such a long time. And I think a lot of that was because there was this sort of overarching view that it was going to be a really difficult guideline to produce because of a lack of data in this particular field. And yet that actually isn't completely true, as I'm going to come on to mention. So in terms of the sort of general process of producing guidelines at the BAP, they are much less hidebound around the methodology than NICE guidelines. The guideline is first of all generated, the bare bones of it are generated out of a consensus meeting with psychopharmacological experts. It was a much broader group with regard to the perinatal consensus group, and I will come on to that in 1 second. There is a real emphasis on reviewing the existing evidence and guidelines. Again, especially looking at the NICE guidelines. It's really important that clinicians are not faced with a situation where they have conflict between NICE and BAP guidelines. And again, I would say that that is particularly important with regard to BAP, the perinatal guidelines. And again, I'll mention that again in 1 second. We try and focus on areas of uncertainty, or that's what I believe guidelines should do. I think that NICE are going further and further away from that and actually just focusing on areas of certainty rather than uncertainty. And one questions the wisdom of that, because that's not really what clinicians are in need of. It is really important that people understand that guidelines are not diktats. They certainly should not be diktats, and following guidelines blindly can often do far more harm than good. And again, I would suggest that might be particularly the case in the perinatal area. What they should be there to do is to help support a shared decision-making between the clinician and the patient. And that was something that we really focused on when we were putting these guidelines together. So here is the front page of the guideline. You can see that there is a large number of authors. There are a lot of perinatal psychiatrists amongst the group of authors, including some that are sitting in the audience here. But we also had people who had expertise in other areas. So my major background is in mood disorders, as is Alan Young. We also had people such as Anne Lingford Hughes with expertise on substance misuse. But we also had individuals who are developmental biologists, such as Vivette Glover. We had teratologists involved, including Laura Yates, who leads the UK Teratology Information Service. So if you ever are wanting to find out about the risks associated with particular drugs and can contact UK TIS, that is the service run by Laura Yates that is actually based in Newcastle. So we've really got a very broad range of individuals. We also had service user involvement in the consensus meeting, fed in quite a lot in terms of how the guidelines were going to be structured and some of the major points that we're going to make. So I emphasised the importance of this guideline linking in with the NICE guidelines. I think this is really, really important. This whole perinatal area is an area of great anxiety for patients and clinicians. I would suggest that it's probably one of the most anxiety-provoking areas to prescribe in, of any that we prescribe in mental health. And what's only going to make that anxiety far worse is if we have a situation where we have NICE saying one thing and the BAP guidelines saying another. So this guideline, the BAP perinatal guideline, started off as long ago as 2014, and it didn't get published until 2017. And one of the reasons for this 3-year-long gestational period was the fact that NICE then went into a situation of reviewing their perinatal guidelines, and we decided to call a halt to the development of the BAP ones until NICE had actually published theirs, so that we could actually reflect on those and try and identify where and how the BAP guidelines could supplement the NICE guidelines rather than cause any conflict. So in the NICE guideline, published in 2014, there was again an emphasis on shared decision-making, and the statement that the clinician should discuss treatment and prevention options and any particular concerns the woman has about the pregnancy or the fetus or the baby, provide information to the woman, and if she agrees, her partner, family or carer, about, and then these 4 things here: the potential benefits of treatment, the possible consequences of no treatment, the possible harms associated with treatment, and importantly, and this was something that was new to the 2015 NICE guideline, was what might happen if the treatment is changed or stopped, particularly if that occurs abruptly. Because this is something that we know in clinical practice happens all the time. A patient discovers that she is pregnant and then decides that she's going to stop all medication because she does not want her unborn child exposed to any risk that might come from the actual medication. Now, what I would suggest is that NICE guideline provides an awful lot of very useful information, particularly around service provision and integration of different services. But what I would also argue is that there is actually relatively limited information provided to clinicians as to what they should be saying about these specific points. So what we focused on in the BAP guidelines was providing clinicians with the information that they can then use to address these points when they are discussing things with the woman and her family. So here we have the BAP 2017 perinatal guidelines. And what we did was we reviewed the issues around risks of the illness themselves, both on the mother and on the child, the effectiveness of medication in pregnancy, or put the other way round, the risks of medication being discontinued, and the risks of medication to the fetus or the infant. This is the point that patients often focus on. They want to know what are the risks of these medications. But what is often ignored in the discussions are the risks of the illness itself and the risks of removing the medication during pregnancy. So the guideline was divided into 4 parts. So parts 1 and 3 were looking at the risks of the untreated illness and the benefits and harms of the individual treatment. And then 2 and 4 were about how to then do things. Section 2 was generic guidance, or is generic guidance, on using medication, and Section 4 are specific recommendations about how to treat different disorders with pharmacological treatments. And we have tried to be extremely comprehensive, so that was one of the major challenges, and one of the reasons why the guideline took so long was that we've actually got broader coverage of treatment of conditions in the perinatal guidelines than we do across all of the BAP guidelines in toto. What we would argue is that this section here, this generic guidance, is potentially the most important of it all. And that was the most important consensus view that came out of the consensus meeting. So I'm going to go through each of those sections in turn. I am not going to cover every single condition and every single group of pharmacological agents that are covered in the guidelines. I'm going to be focusing on depression, bipolar disorder, and schizophrenia. I would really emphasize the importance, for example, of the sections on substance misuse, because we know that there are high rates of substance misuse, particularly in patients with mental health problems who are pregnant. So there are a number of generic points that we can make about untreated illness in pregnancy. The first being that pregnancy is not guaranteed to be a time of great celebration, enthusiasm, and feeling all is well with life, the world, and the universe. Some women who are pregnant continue to have significant mental health problems. Pregnancy is not protective. We also know that women with mental health problems tend to engage with antenatal care in suboptimal ways, with higher rates of nicotine, alcohol, and other substance misuse. And we know all of those can have a detrimental effect on child outcome, pregnancy outcome. We also know that mental illness during pregnancy can have a negative impact on the family, on other children that are in the family, and on fathers. And there is an increased rate of paternal mental illness in families where the mother has a mental health problem. If we look at specific conditions, most of the work looking at the impact of illness during pregnancy has related to the risks of untreated depression and anxiety. And what I would caution you is that much of this data relates to the presence of depressive and anxiety symptoms rather than necessarily a full-blown syndrome of depression and anxiety. A lot of this is large epidemiological studies, particularly from using the ALSPAC cohort that's recruited around Bristol, where children have been followed up for more than 2 decades now for mothers who gave birth in the Bristol area, many of whom had mental health problems. And what we know is that depression and anxiety symptoms in pregnancy are associated with low birth weight and preterm delivery, and that these do appear to correlate with the severity of depressive symptoms. We also know that there are many adverse childhood outcomes for children born to mothers who had mental health problems during pregnancy, including emotional and conduct problems, and also a potential increase in ADHD. One wouldn't be surprised to imagine that there may be problems with engagement and bonding for the children born to mothers who have significant mental health problems. And there is increasing evidence that's been increasing even beyond when these guidelines were published of long-term behavioural and mental health problems in the offspring of mothers who are ill during or immediately after birth. Another caveat that one must be aware of, though, with all of this data is that most of the analyses do not take into account shared genetic risks. Obviously, a mother who has mental health problems may well have had an increased genetic risk of this, and that may well have been inherited by the offspring. In terms of bipolar disorder and schizophrenia, there is much less data around what impact these can have on the unborn child. What we do, however, know is that bipolar disorder is associated with a massively high risk of postpartum illness. It is by far and away the biggest risk factor for an episode of severe postpartum depression, and most particularly postpartum psychosis. The risk is increased from maybe as low as 1 in 1,000 women to maybe as much as 1 in 4, a 250-fold increase. So it is a massive increase in the risk. And what we know is that recurrence without treatment is higher than would be expected if you just take a group of women, take them off their long-term medication, and see what happens to them. So pregnancy and certainly childbirth itself is a major risk factor in bipolar disorder. In schizophrenia, pregnancy is also not protective, and we know that schizophrenia is associated with a range of adverse obstetric and neonatal outcomes, for example, babies being born small for gestational age. But again, there's more limited information and data than there is for anxiety and depressive symptoms, particularly subsyndromal anxiety and depressive symptoms. So let me move on to the second section of the guidelines, having highlighted that psychiatric illness during pregnancy is a risk factor for the unborn child. The second section in the guideline is looking at how medication should be used in the perinatal period. And as I've already said, the consensus guideline group believed that this is the most important section of the guidance. And yet I've only got 2 slides to show you on it. The first is emphasising some of the weaknesses in the data. As I said right at the beginning, there was a lot of concern that we don't have much data, and that's not entirely true, as you're going to come on and see in a second. But what we do know is there are a lot of caveats and limitations in what data we've got, even in those areas where we have more data. What we know is that there is a tendency for over-reporting of abnormalities that occur in babies exposed in utero to medication. It is not surprising. If a mother is exposed to medication during pregnancy, they and the clinical staff are likely to be much more observant of abnormalities in children that are subsequently born. What we also know is that in many of the papers and studies that have looked at the rates of abnormalities in babies exposed in utero, minor and major abnormalities are lumped together. The cardiac abnormalities are probably the easiest and best example of that. Often life-threatening cardiac abnormalities are lumped together with trivial and functionally insignificant abnormalities. If you do high-resolution cardiac ultrasound scans, you can detect, for example, small atrial septal defects that are of no functional significance whatsoever to the child, but they would still be flagged up as an abnormality. And in many studies, these are not differentiated from life-threatening ones. Confounding factors are not always taken into account, and even when you go into the process of statistically adjusting for these confounds, you can never guarantee that you have accurately and fully addressed for all of the confounds. And I've already emphasised the rates of alcohol and nicotine are increased in mothers with mental health problems. One of the other issues from a positive point of view is we want to know how effective drugs are in pregnancy, and we have next to no data around the efficacy of drugs in pregnant women. For obvious reasons, there are no randomized trials specifically in pregnant women. But there is no suggestion that efficacy would be different, and one has to question, why would you think that the efficacy of medication would be any different? But it is an extrapolation from the general population. But this, in many ways, is the most important slide of my entire presentation. These are the general principles that we agreed in the consensus group with regard to the use of medication in the perinatal period. And that it's not rocket science. What it's emphasizing is the importance of really good clinical practice. As often happens these days, clinicians are seeing patients infrequently or only once off. They're a new consultant in a particular service, or they're one of a number of locums covering a particular service, given the fact that we have 9% vacancies of consultant psychiatry posts across the UK at the present time. And when you are in that situation, it is very difficult to take that longitudinal perspective. It's very easy just to focus on the current situation. But the importance clinically across the board, but particularly in the perinatal period, is being able to take that longitudinal perspective with a particular patient. So in other words, how frequently has this illness relapsed in this particular woman? And what happens when it does? Are relapses relatively mild, or are they severe? How easy are they to get under control with medication if relapses occur? How helpful has medication been at both treating the illness but also preventing relapse? How many different medications have needed to be tried before one that works for that woman has been identified? Because the most important thing of all is to make decisions individualized to that individual patient based upon their own illness and their own past treatment history. These are the most important questions when you are asking what drug, if any, should be used and how should it be used for that woman. Obviously, it is worthwhile considering non-drug alternatives because any exposure to any agent in utero is going to increase the risk, possibly, to some extent, for something. So we do want to try and minimize that. So we want to consider non-drug alternatives, and fast tracking for psychological therapies may be something that is important to consider, and many places around the country now do have that fast tracking system for pregnant women. We also want to rationalise treatment if at all possible. We find patients on multiple antipsychotics, for example. Do they really need to be on 2 different antipsychotics? Do they need to be on 2, 3 different anti-manic treatments? Do they need to be on a long-term benzodiazepine? Do they need to be on 2 long-term benzodiazepines? We need to look at how we can rationalise the treatment as much as we possibly can. And then we need to follow the patient up closely and assertively, making sure that we are actively engaging with that patient, even for patients that don't engage as well as they might with follow-up. And we need close collaboration between services, between primary and secondary care and obstetric services, fetal medicine specialists if necessary, and remembering that within mental health services, we're potentially going to need collaboration between CMHTs that may be following the patient up initially, and perinatal services, and potentially inpatient services and mother and baby units. So there's a lot of different teams that need to know what is going on with the particular mother. So let me move on to section 3. What are the benefits and harms associated with individual treatments? As I say, I'm not going to run through every single treatment that we consider, just a couple of different examples. And let me start with antidepressants. And this is the place to say that the myth that we have little data around treatments in pregnancy is just that. It is a myth, and it is particularly a myth with regard to antidepressants. We now have data from hundreds of thousands of women who have taken antidepressants during pregnancy, so we are increasingly aware of the risks associated with in utero exposure. Now, the data, despite that, is still difficult to interpret, predominantly because of the issue of confounds. What we tend to notice is that children born to mothers who had treatment generally are better off, ultimately, than women who have untreated depression. So trying to balance up the risks of the illness and the risk of the treatment, the risk of the illness seems to outweigh the risk of the treatment for many patients. That is particularly the case with more severely ill patients. Patients with mild depression, it is a more questionable finding. But certainly patients with more severe depression, the risk of the illness is probably higher than the risks of treatment. The data on the risks for individual antidepressants is difficult to understand at times because of the number of uncontrolled variables and confounders. There are a few studies that have controlled for every single possible confounder because it is impossible to do so, and you would need even larger data sets than the data sets that are in existence. But what we tend to see is a picture that as time goes by and the amount of data increases, the magnitude of any particular risk appears to get smaller and smaller. SSRIs appear to be associated with an increased risk of postpartum hemorrhage. One might imagine that. SSRIs inhibit platelet aggregation. It is one reason why they can lead to problems with gastric bleeds in elderly who are prone to that, and also why you may get better cardiac survival in depressed patients post-MI when you give them an SSRI, because the SSRIs are actually reducing platelet aggregation and actually improving or decreasing the risk of adverse cardiac events. But the downside is that they will slow clotting and therefore increase the risk of postpartum hemorrhage. But the important point here is the absolute risk is low. There is a potential increased risk with SSRIs of ASD and ADHD. But again, this is a good example of where the magnitude of that risk has gone down with each successive study that's been reported. And it is still not conclusive that these risks exist and are not due to some ongoing confounders. If you have a patient who has never been on any antidepressant, who becomes severely depressed during pregnancy, and you ask the question, which would be the best antidepressant to use, the Guideline Development Group agreed that we would recommend sertraline, because of low rates of adverse effects in breastfed infants, and usually are thinking about continuing this drug postpartum, and all drugs that can get into the brain to some extent or other will get into breast milk. So this may be a good choice for first episode patients. However, in bold, we are not recommending that every woman who is pregnant who needs an antidepressant should go on to sertraline. Quite the converse. We are recommending that the individual's patient history should be the most important factor in terms of choice of medication. So we need to be guided by the previous response in previous episodes. It is idiotic to say that a woman who has failed to respond to one or two different SSRIs, who finally responds to an SSRI like venlafaxine, should have that discontinued and then switch to sertraline when they are pregnant. If they need an antidepressant, they need an antidepressant they are going to respond to. The best indicator of which antidepressant they will respond to is their past history. So it is really important to emphasize we are not trying to make some blanket ban as to which antidepressant to use in all pregnant women. Antipsychotics. Well, again, we have increasing amounts of data, not as much as with antidepressants, but certainly much more for second-generation antipsychotics than first-generation antipsychotics. And the greatest amount of data is with quetiapine, olanzapine, and risperidone. What we would say is that there is little evidence of risk with either first or second-generation antipsychotics, particularly around teratogenicity. There may be an increased risk of diabetes. Some data that we obtained in Newcastle suggests that the second-generation antipsychotics, particularly olanzapine, particularly clozapine, may be associated with gestational diabetes. And what we would recommend is that any woman who has been prescribed an antipsychotic through pregnancy should have this their weight and the risk of gestational diabetes monitored closely. There is a possible risk that babies who are exposed in utero to antipsychotics have neurodevelopmental delay that's observable when they're 5 or 10 years old. But the data is very limited, as one can imagine. It is very difficult getting data from children who are 10 years old, detailed neuromotor ability from 10-year-old children who were exposed in utero to antipsychotics. Again, just as with the antidepressant, the best indicator of which drug to use is the patient's past history. And we were not recommending switching of medication because the risk of relapse is high. If an antipsychotic is needed, the best one for the patient is probably the one they are currently on, assuming that they were responding to that. So in other words, use the antipsychotic that has worked best for that patient, with close monitoring of the baby once they're born and breastfed infants. Remember, any drug that gets into the brain has a risk of getting into breast milk. We would say that breastfeeding is contraindicated in babies whose mothers are being treated with clozapine because of the at least theoretical risk of agranulocytosis. So this would be one of the reasons we would say don't breastfeed. Lithium? Well, the data is actually very poor for lithium. If you go into any of the textbooks, they will talk about Epstein's abnormality following in utero exposure to lithium and other cardiac abnormalities, and yet the evidence base supporting the notion that lithium is associated with an increased risk of cardiac abnormalities, and Epstein's in particular, is really very poor. And again, the more evidence we obtain, the lower the magnitude of these risks appears to be. So there's really very little data that can inform us with regard to the precise magnitude of the risk. However, the rates quoted in many of the textbooks are way higher than current evidence would actually suggest. Again, lithium will pass into breast milk, and there is no systematic data on the effects of this, but because of concerns about effects of lithium on the newborn's kidney and thyroid function, again, we would generally advocate avoiding breastfeeding. We mentioned that avoiding breastfeeding for patients with bipolar disorder might be advantageous generally because of the significant impact that sleep disruption can have on bipolar disorder. We do suggest that if patients with bipolar disorder are breastfeeding, that they consider expressing breast milk and having their partner breastfeeding overnight to try and allow the woman to have relatively uninterrupted periods of sleep. And you hope the father doesn't have bipolar disorder. In terms of anti-epileptics and anti-epileptic mood stabilizers, this is one of the few places where the guidelines make a very specific recommendation, and that is around valproate, and that is essentially it should not be used. There is never, ever a situation where you can make 100% recommendation for all patients, and there isn't an allowance for an exception in the guideline. But the general rule of thumb, and it is a very, very firm general rule of thumb, is that valproate should not be used not only in pregnant women, but in any woman of childbearing potential because of the risks of polycystic ovary syndrome, major congenital malformations, and valproate's got the highest risk of major congenital malformations of any of the drugs that we use in psychiatry. And also the fact that exposure in utero is associated with a reduction in IQ and a potential risk of ASD. So there are multiple reasons for avoiding valproate. It does increasingly look like a situation where women who take valproate through pregnancy without proper advice from clinicians are going to be suing clinicians. This is somewhere where you are going to be and risk end up being in court if you do not follow not only the recommendation from BAP, but also the recommendation in NICE and the MHRA. Carbamazepine is also associated with an increased risk of major congenital malformations. The rate is lower than with valproate, so we would suggest that you do not use carbamazepine either. But you also need to remember all the interaction effects with carbamazepine, particularly with the oral contraceptive. So just thinking that a woman is on an oral contraceptive, meaning you don't have to worry about the teratogenic effects of carbamazepine, is unfortunately not true. Lamotrigine, on the other hand, was originally associated with suggestions that it could cause cleft palate and cleft lip, and yet again, with increasing amounts of data, the magnitude of that risk has gone down and down until we've got to the point where we can say that it is probably not associated with teratogenicity. So of these three drugs, the one that we would feel more relaxed about using during pregnancy would be lamotrigine. So finally, section 4, how do we recommend treating various different disorders? As far as depression is concerned, we would say take breastfeeding intentions into account. That's always going to be important. We need to advise patients about the fact that babies who are breastfeeding of mothers who are actually taking psychotropic medication need to be carefully monitored. Consider sertraline for new episodes, but the aim is to use the most effective previous drug if this is a recurrence for this particular woman. And consider a postnatal risk if there is any depression present prenatally, and continue treatment after birth. Anxiety and insomnia, don't underestimate the risks of untreated anxiety. As I say, lots of data suggesting that can have an impact in children and adults who were exposed in utero. Provide access to psychological treatment. SSRIs are still the first-line treatment, as they are in the general population, and we know a lot about these SSRIs. So if you're going to use a drug for anxiety in the perinatal period, then consider using an SSRI. Bipolar disorder, this is in many ways the most complicated situation. We've recommended antipsychotics as the preferred treatment because we've got a larger evidence base and we've got more safety data, and we can be more confident around the safety of the antipsychotics, certainly than with drugs like valproate and carbamazepine, which should be avoided and probably stopped if the patients are on treatment to become pregnant. An important caveat here is folate. There is no evidence that folate is protective against the adverse effects of valproate or carbamazepine. So do not think that is going to get you out of jail free. Lamotrigine, limited data but decreasing concerns. So we certainly do have some patients who are continuing on lamotrigine. Lithium, the magnitude of the risk from in utero exposure is probably not as high as we originally thought. So we do have women who are continuing on lithium during pregnancy. What we do advocate is fetal cardiovascular screening if there is first trimester exposure. One of the important issues with lithium is, as Alan actually mentioned at the end of the last talk, sudden discontinuation of lithium is associated with rebound mania. So a woman who is established on lithium, who becomes pregnant and then stops it suddenly, is at massively high risk of mania. So we always recommend, to prevent that, you need gradual tapering of the lithium. Gradual tapering of the lithium will take at least the first trimester, which is the major risk period for exposure to lithium. So this is something that has to be thought ideally preconception, rather than waiting to the point that the woman suddenly declares that she is pregnant. So if we are going to stop it slowly over 4 weeks, but consider restarting, say, for a woman who stops preconception, who has responded well to lithium, saying, I do not want to expose my baby to any risk. That's a fair enough point to make. Comes off the medication, gets pregnant, and then you might consider restarting in the second or third trimester when the risk may be slightly lower. You need to monitor the levels of lithium fairly closely, and there is clear guidance as to how to do this, both in the BAP and NICE guidelines, because initially they tend to fall, but they can rise again, and there can be sudden changes in lithium levels around the time of delivery. So it's particularly important to monitor during delivery. And if a medication has been stopped, consider restarting it immediately postnatally. So a woman who comes off preconception, stays off right the way through pregnancy, you need to consider restarting medication. And when we say immediately, we're meaning really between the birth of the baby and the placenta. Okay? It needs to be sort of that quickly. All right? You need to get in quick because the risk of relapse is highest within the first week, indeed within the first 24 hours. So getting medication in early is the thing to think about. In terms of schizophrenia, think about prolactin-sparing drugs pre-conception, because if you don't, then you're going to run into problems with conception. The risk of relapse is high, but postnatally, but not as high as with bipolar disorder. But if you're going to continue treatment, continue with a medication which is proven to be effective in that particular patient. And the risk is highest in the postnatal period. So my conclusions are, we need to go for shared decision making. This is an anxious time for the mother as well as you, the clinician. You need to work together, but that does not mean to say you abrogate your responsibilities as a clinician and just say, well, you can do whatever you like. What do you want to do? You need to be going through with the patient the various different risks and benefits that need to be considered. Remember the risk of untreated illness. It's something that patients will often forget. The generic management recommendations are the most important, and that is particularly taking the individual patient perspective into account and their past treatment history. There are very few absolutes. Mostly, as more data is obtained, the concerns of risk get less, such as antidepressants and persistent pulmonary hypertension of the newborn, lamotrigine and cleft palate, lithium and Epstein's. The exception are the concerns about valproate, where the risks have not got less with more data, they've just been firmed up. The quality of data continues to be poor, though, particularly with regard to developmental impacts, and that's something we really need to focus on. And just before I conclude, this has come out of the BAP. The BAP organise a whole range of educational activities in addition to the guidelines, and a new addition to the educational portfolio is the Applied Clinical Sciences stream that runs in parallel with the summer meeting. This was the second time, this year is the second time we've run an Applied Clinical Sciences stream, and it is going to be on the 22nd to 23rd of July at Imperial College. It's the afternoon of the 22nd and the whole of the 23rd, and the focus is on psychosis, where there are sessions on early intervention, issues around metabolic disturbance, some of the problems that Robin was talking about earlier on, and how we should be managing treatment-resistant schizophrenia. The guest lecture for the summer meeting as a whole is also Danny Weinberger, looking at the genomic insights into schizophrenia. So a real tour de force from Danny Weinberger as a highlight to this Applied Clinical Sciences stream on psychosis. So I would highly recommend this. You can find out more about it by going to bap.org.uk, where you can also find the perinatal guidelines and download them free of charge. And the flyers about the summer meeting and the Applied Clinical Sciences stream are also up at the front desk as well. So no excuse for not knowing about it and hopefully coming along to it. Thank you very much indeed.